Bonjour à toutes et à tous. Je m'appelle Anne Lagacé Dowson de la Coalition canadienne de la santé. I'm Anne Lagacé Dowson of the Canadian Health Coalition, which is a pan-Canadian and broadly based coalition of individual Canadians and Quebecers, researchers and experts, and healthcare unions, as well as civil society groups. So we at the coalition would really like to see better healthcare and better health outcomes for Canadians and Quebecers. And that means pharmacare for all, which is our theme and message for today, pharmacare for all, l'assurance médicaments pour tous et toutes. And we really would like to see C-64, the pharmacare bill, passed third reading by the end of the session, before the House rises, and then on to the Senate. This has been a long time coming. It's been recommended repeatedly by any number of official bodies. And so we are very happy to see how far it's come, and we'd like it to cross the finish line. We've brought together 3 Canadians who know a lot about the issues, and they join me today on stage and about why we need pharmacare. Frederique Chabot is head of Action Canada for Sexual Health and Rights, and Mike Bleskie is a diabetes activist with type 1 diabetes. And behind me on the screen on Zoom is Professor Steve Morgan of the University of British Columbia, one of Canada's leading experts on the economics of healthcare and on pharmacare and drug policy. So I'm going to hand the microphone over to Frederique, then Mike, then Steve, and we'd be happy to take questions at the end. Thank you very much.
Merci, Anne. Thank you. Nice to be here with everyone. I'm here with Action Canada for Sexual Health and Rights. We're a national organization advancing sexual and reproductive health in Canada and around the world. Today, I stand before you as an advocate for a cause that affects every single one of us, the accessibility of prescription contraception. This issue is not merely about medicine. It's about equality, health outcomes, and financial stability. It's about ensuring that every person in Canada, regardless of their income or financial situation, has access to the medications they need without the burden of cost. The introduction of a single-payer universal pharmacare program, starting with contraception and diabetes drugs, marks a monumental step forward. This is the biggest healthcare news since the Canada Health Act, and a sign that people's demands that our healthcare system be a political priority is being heard. This initiative will have incredibly positive impacts on people across Canada. By prioritizing contraception as one of the first classes of medication, we are not just addressing individual health needs, we are transforming lives, families, and communities for the better. This is excellent news, and it's imperative that we support this initiative wholeheartedly. Now let's talk about the profound effects of contraception coverage. It's not just about preventing unplanned pregnancies. It's about empowering individuals to make choices about their own bodies, their relationships, when or with whom to become parents, their studies or career. At the end of the day, it's our ability to choose our own path. It is also about supporting families and strengthening communities. Families that can choose when and how to space their children and have what they need to make decisions that support their best interests and those of their children thrive. Communities where families are planned and where people have access to the reproductive health care they need see reduction in overall poverty, in child poverty, and in family violence. When contraception is covered, individuals are not forced to choose between the cost of contraception and their living expenses. Imagine the relief of not having to save up for an IUD, which can cost up to $400, or having to decide between paying for the pill or essential items like groceries or rent. These impossible choices that often make us prioritize short-term essential needs over what can benefit our quality of life over time are the reality for far too many people, and it's time for change. Some may argue that this is not needed and that we should just add coverage that addresses current gaps, but this approach falls short and misrepresents what kind of gaps currently leaves people without access. First, people who have inconsistent access to insurance because of the type of jobs they have or because they don't quite meet the threshold of other types of coverage are often women and low income. They fall through the cracks. Second, many insurance plans do not cover all options needed for real choice or have restrictions of what is covered, which can impact people's health and well-being. Third, controlling what is accessible to whom through compassionate programs that fuel Coercive contraceptive practices, where you have a choice between nothing or what is made available to you for free, is a problem. For example, Black and Indigenous young women and disabled women are disproportionately offered long-acting forms of contraception, even when that is not their preference or doesn't work for their bodies. Fourth, many people access insurance for medication through other people, which creates gaps in access that are invisible in spreadsheets. A woman who is in a situation of intimate partner violence with access to insurance only through a partner who is controlling her access to contraception, which is called reproductive coercion, does not have access to contraception. A young person who can only access coverage through parents who disagree with their decisions to go on birth control does not have access to birth control. People who can only get coverage for a type of contraception that makes them sick and can't afford the contraception that would work best for them does not have access to contraception. A single-payer, universal approach is the way to go. It ensures that everyone has equal access to contraception regardless of their circumstances. It allows people to choose what works best for them. Anything short of this is not being argued in the best interest of the public. Let's not forget the medical conditions that contraception can treat, conditions like endometriosis, polycystic ovary syndromes, and premenstrual dysphoric disorders. This can take people out of their jobs. By making contraception accessible to all, we're also addressing significant gaps in care that people have struggled with for too long. We got the best piece of news last February when this big idea came to pass. I urge every one of you to support the call for universal pharmacare, starting with contraception and diabetes drugs. Let's stand together to ensure that everyone in Canada has access to the medication they need to live healthy, fulfilling lives. Let's focus on building the kind of healthcare system we can rely on when we need care or when our child is sick. This includes pharmacare. Thank you.
Merci, Frederique Chabot. I pass the microphone to Mike Bleskie, diabetes activist.
Thank you. My name is Mike Bleskie, and I've been waiting for a universal pharmacare system in Canada for almost 20 years of my life. When I was diagnosed, I was a scared 12-year-old kid who had no idea of the impact that diabetes would have on my life. For 2 decades, my world has been tied to multiple injections every day, or having an insulin pump attached to me 24/7. I've come to terms with riding a delicate balance between debilitating low blood sugars that can knock me out, or dangerously high blood sugars that can come with the long-term risk of blindness, amputation, heart disease, and other side effects. Back then, optimism was high about the potential of stem cell and islet cell therapy for providing a cure for type 1 diabetes. Despite promising breakthroughs and the efforts of the world's best research talent, much of it happening right here in Canada, we still do not have a cure, and the rituals of monitoring and taking insulin still continue to this day. And while treatment technologies have improved significantly in the past 3 years, the financial cost of living with type 1 and type 2 diabetes in this country remains strenuous at best. For me, a precariously employed 30-year-old on an insulin pump with no insurance, the out-of-pocket cost of diabetes supplies is approximately $450 per month, plus the cost of insulin itself. The combined Ontario Drug Benefit and Assistive Devices program only covers a portion of these out-of-pocket costs. Once I pay for my rent, my food, and my medication, I'm left with almost nothing. This problem leads to situations where I'm forced to consider rationing my infusion sets and my cartridges, a decision which can lead to consequences like infection, permanent tissue scarring, or other long-term complications. And I'm not alone in this. 300,000 Canadians live with type 1 diabetes, and the rate of new cases is sitting at 4%. That number will outpace the growth of the general population. This is only a fraction of the 3.7 million Canadians living with some form of diabetes or prediabetes who depend on various types of medication to stay in control. A perfect storm has brewed in Canada. There are now more diabetics in Canada than ever before, making up 10% of the population. More Canadians work at part-time, contract, and casual positions where the employer does not provide insurance. Average Canadians are finding out the hard way that their pre-existing conditions either disqualifies or prices them out of buying their own private insurance plans. There are also many Canadian diabetics in retirement age who live on fixed incomes and find themselves navigating an asymmetrical provincial patchwork of medications covered under existing drug plans for seniors. This doesn't even take into account the existential threat posed by American patients crossing the border to buy Canadian insulin stocks, or people using diabetes medications like Ozempic for off-label use. It's time that we recognize that universal, public access to basic medications is not a luxury. It is essential for all Canadians. Pharmacare represents the most effective, efficient, and equitable means to ensure that every person with a pre-existing condition can treat themselves, achieve their desired health outcomes, and avoid a hospitalization further down the road. Providing access to insulin, metformin, contraceptives, and future medications down the line will mean that Canadian workers, students, retirees, and business owners will be able to rely on access to their medications at a bare minimum of cost, thanks to a single payer model. The only obstacle is the political will to make this happen. Right now, we're seeing political games unfolding with the official opposition blocking debate on the Pharmacare Act with an amendment which I can only describe as a childish act of political gamesmanship. My message to the Conservative Party is this: stop treating diabetics like chess pieces in a game. This isn't a game. You're playing with our lives. I'm asking all parties to support the Pharmacare Act and to make sure that it passes this summer. Thank you. I would like to pass it on to Steve, who is on Zoom.
Thank you, and thank you for the opportunity to speak today. I'll keep my remarks brief so as to allow more time for questions. I want to start by saying, based on 30 years of studying pharmacare systems around the world, that Bill C-64 can, if the government has the political will, move us forward to the fairest and most efficient system of covering prescription drugs in Canada or any other country for that matter. Now, Canadians are hearing a lot of rhetoric about national pharmacare these days, much of which is false. And amidst this noise, I think it's important that Canadians know that the pharmaceutical industry is an extraordinarily complex and challenging sector, clinically, economically, and indeed politically. Around the world, it is growing ever more difficult for countries to manage owing to the changes in drug development, marketing, and pricing, and frankly, owing to the extraordinary power of corporate interests in the sector. A public national pharmacare system can give a country the institutional capacity to manage these challenges both fairly and effectively. Now, it is a truism that the value of medicines cannot be realized if patients cannot afford access to them. Indeed, as you have already heard today, and as I can tell you, volumes of scientific research shows, financial inaccessibility of necessary medicines causes real harm to patients and to healthcare systems. This is the main reason why every comparable country with a universal healthcare system provides universal coverage of prescription drugs at little or no direct cost to patients. It is also a truism that the value of new pharmaceuticals is systematically exaggerated by manufacturers. Pharmaceutical companies are keen to reap what are sometimes extraordinary profits during the relatively short term during which they are legally protected from competition by way of pharmaceutical patents. The intense pressure to achieve as much sales as possible, as quickly as possible, can give rise to very serious problems of overprescribing and excessive pricing. So even when patients can access medicines, harm can still be done to both them and the healthcare system when drug utilization is not appropriate and when drug prices are not reasonable. Pharmacare systems can create balancing powers in this market to prevent these problems. And one thing that is becoming increasingly clear is that countries should not leave the management of this important component of healthcare to for-profit insurers. There is growing evidence from the United States and indeed Canada that private insurers can profit from confidentially negotiated supply arrangements with drug manufacturers and retail pharmacies that can actually inflate drug prices and distort important choices about patient care. This too can harm both patients and healthcare systems, even when it appears that everybody is quote unquote covered for prescription drugs by way of privately managed plans. Given all of this complexity, Canada should be working to build the institutional capacity to promote the laudable goals of universal and equitable access to appropriately prescribed and affordably priced medicines. Research unequivocally shows that a national pharmacare system that is publicly financed and publicly managed can do just that, especially in the context of a public healthcare system like Canada's. Covering contraceptives and diabetes treatments through such a national pharmacare system would be a landmark achievement for Canada. It is arguably long overdue and represents just one step in a long policy process, but it is a step in the right direction, and it can be followed quickly by coverage of a much wider range of essential medicines, as is alluded to in Bill C-64. With the right follow-through, Bill C-64 is an exceedingly rare window of opportunity for a truly transformative change in Canada's healthcare system to make the healthcare system better for generations. I hope the government has the political will to do just that. Thank you. I'll hand it back to the moderator.
Very much. We just heard Steve Morgan on Zoom from the University of British Columbia. He's in Vancouver. Previous to him was Mike Bleskie, diabetes activist, type 1 diabetic, and Frederique Chabot of Action Canada for Sexual Health and Rights. And now I guess we'll open it up to questions. My colleague Steve Staples, who is policy director at the Canadian Health Coalition, perhaps you could join us on stage if there are any questions. So I just open it up. Please jump right in. Tessie?
Hi, thank you. My name is Tessie Sanchi, and I cover Health for Hill Times Research. Steve, I'll start with you, and anyone else can jump in, because Steve, you were talking about the truisms of what the insurance companies are saying. So I've spoken to some of those, and I'm going to read you something that someone told me just about access and about filling the gaps. And I was told that a provincial public plan typically covers 4,000 to 5,000 drugs, but private plans can cover upwards of 10,000 drugs. Their point being this is an access issue. Why would we give everyone the same coverage if folks on private plans may actually have access to a wider range of medications, etc.? Can you speak to that?
Yeah, I can speak to 2 points. One of them is that it's a distortion of facts, and there is a body of literature which I recently did a systematic review on around the drugs that are covered by national pharmacare systems around the world. And it basically points out that health systems make choices about drugs that are have the best evidence of safety, efficacy, and value, and cover those medicines. Newer drugs that are not yet proven, or older drugs that have better substitutes for them now, might not be covered by those systems, and that's okay. But the argument that somehow there's twice as many drugs covered by private drug plans is a distortion of reality. Canada's public drug plans actually cover a very comprehensive suite of prescriptions that Canadians need. There will always be some debate over the latest drug that may have equivocal evidence surrounding it, but the systems work. And one of the things that insurers need to be pushed back on is this notion that somehow they'll disappear if Canada has a national pharmacare program. Employers and unions want a national pharmacare program so that it can make extended health benefits for the rest of their healthcare needs stronger and more affordable. So if we build a national pharmacare program that at least establishes a basis of the drugs that every Canadian should have as a right as citizenship, and the drugs for which we should have national procurement contracts to be sure that those are available to us when we need them, then you can have private payers pay extra have private insurance for the additional choices that are beyond that envelope of medicines of greatest proven value.
Angel, thank you. Add to that point, I want to also bring attention to the work of the contraception and abortion research team out of UBC, who does excellent work on contraception coverage and speaks to differences that I'm seeing in terms of report of how many people are not covered versus people who have access to some kind of coverage through either provincial or compassionate programs or insurance. And in reality, there's a lot of people who fall through the cracks, I know especially for contraception. And as I was mentioning, there's different types of access issues that are not addressed when we are simply taking a gaps approach with insurance. So people who have access to insurance through third parties, through others, through family members, people who are changing jobs often, who have precarious employment, or because they can't access the kind of medication that actually is appropriate for them through whatever program is made available to them, create health outcomes that are negative for several members of our community. So again, I think it's important to say that anything other than universal single-payer systems is not being argued in the interest of the public. There are other interests at play, and instead we should focus on what would deliver the best outcomes for people in Canada. Thank you.
I just wanted to mention the National Farmers Union of Canada just recently joined our campaign in support of it, and they pointed out that 6.5 million Canadians do not have doctors. They end up at emergency rooms, trying to get care. Increasingly, ERs are kind of walk-in clinics, and they are while they wait to see somebody, in desperation, they don't get access to prescription medication. They don't get their meds. So something needs to be done to take the pressure off the hospital system and also allow people to get access to their medication. Increasingly, the Canadian Federation of Nurses Unions has recently did a campaign, and their image was somebody cutting their pill in half. Many of us know people who do that, and thereby are endangering their health, winding up in the healthcare system, and sometimes very ill and costing much more than they would if they were allowed to get, if it was facilitated for them to get access to their medication, which is one of the themes of our campaign, which is why we're pushing for pharmacare for all. We would like to thank the NDP and the Liberals for pushing it this far. I would underscore what Mike was saying about the games that are being played by the Conservatives. We really think this is in the best interests of the vast majority of Quebecers and Canadians. And as you heard Steve Morgan say, even private interests, many of them are in favor of this. So the Conservatives might want to delay, but really we just need to push ahead with this. It's the best thing for all of us, everyone in this room and everyone who's listening and everyone across the country. I don't want, if you want to add something, Steve Staples?
I think Steve got it. You guys all got it.
Okay.
Same question, please. You're calling for the passing of this bill at third reading in the House by June. I always think of the calendar. We have 5 weeks left. So if the organizations, and Michael, feel free to speak if you plan on sticking around, but what are you guys doing over the next 5 weeks to really get the message across that this needs to be pushed through?
Well, we're here. We were recently here in February. We brought 100 healthcare workers up onto the Hill to speak to MPs and senators. We have an online campaign of signatures we're gathering. We continue to pressure. By today, we're going to go and visit more MPs and their staff to talk more about this issue. And we have put together a video of various people from the healthcare sector, which we're going to release later today, Voices for Pharmacare in French and English. We are doing the best we can. Obviously, the forces arrayed against us are extremely well-connected and have very deep pockets, but this is an issue of equity and fairness, and Canadians are, above all, fair, and I think believe in the concept of equity. So we are continuing to pressure as best we can. And you ask a good question. I guess we'll have to get a little bit creative in the next little while. But the process is pretty far along, and it has a lot of support, so we're very optimistic. But the reason we're here is to keep the pressure up, and we brought together these formidably articulate people to make that position clear. So I wonder if anybody wants to add anything.
So similarly, we are interested in keeping the pressure up. This is an incredibly positive development for healthcare in Canada. We are working with colleagues across the medical field as well, and medical associations such as the Society for Obstetrician Gynecologists of Canada, our colleagues at UBC, so from the Contraception and Abortion Research Team. We are working with doctors, individual doctors in Canada who speak about the experiences of their patients, such as Dr. Rupinder Tour, who's been instrumental in speaking for the coverage of contraception and its importance. We are also working with regional advocates because this is something that has incredible popular support. So Action Canada recently did some polling to see what were the kind of sexual and reproductive health care Canadians most value across the country, and contraception care definitely rises to the top. This is something that is a high priority for Canadians, and there are groups of nurses, medical students, citizens, and parents, families who are getting together to ask for their provincial government as well to put pressure on seeing this bill passed and then entering these bilateral agreements for this to be a success in the years to come. So great question. Thank you.
And while I don't necessarily represent one single organization, I can tell you that the type 1 diabetes community has been asking for this for eons, and we're not going anywhere. We don't really have a choice in the matter. We remain ready to talk to decision makers and policymakers about how it impacts us. I know that healthcare practitioners and physicians that are in diabetes education programs across Canada are chomping at the bit to talk about how access to not only insulin but also medical assisted devices like insulin pumps has a huge impact on outcomes. Organizations such as the Juvenile Diabetes Research Foundation have warmly welcomed the deal on pharmacare as a huge advancement for the care of type 1 diabetics and type 2 diabetics across the country. And we just want the opportunity to have those conversations with the people that are here on Parliament Hill, as well as in provincial legislatures that are making those decisions.
So, hearing no further questions. Okay, so hearing no further questions, we'll adjourn this news conference, unless Steve Morgan on Zoom wants to add one final word.
Yeah, I guess I will. And one of the things I would encourage the media to realize is that this is Canada's Clinton health reform moment. If you remember back to the 1990s when Hillary Clinton's husband put forward her proposals for a universal, largely public health insurance system in the United States, the insurance industry and the medical associations and pharmaceutical companies attacked that program viciously and dishonestly through a campaign that was unprecedented, even in the United States. Canada is witnessing that right now with respect to pharmacare. There are so many distorted statements about the perils of a public program that are coming from vested interests or people who are beholden to them. I would encourage journalists to take the extra time to reach out to whether it's Dr. Eric Hoskins, the chairperson of the government's advisory panel on national pharmacare, or any other credible expert, just to be sure before you publish a statement about the perils of a public system, to be clear that the private-public mix that Canada has right now and that insurers and pharmaceutical companies would like us to continue to have is very much like the U.S. healthcare system. It is the worst way to structure healthcare that you could possibly imagine for any country. And moving forward with a public system is truly in the best interest of Canadians, of taxpayers, employers, and families. Thank you.
Thank you very much, Steve Morgan, Mike Bleskie, and Frederique Chabot. Thank you to all of you, and thanks to the Press Gallery for your exemplary institutional support. And I'm just going to close with one of our favorite hashtags at the Canadian Health Coalition, which is "Profit doesn't care, but we do."
Thank you.
Merci. Merci à tous. Merci à toutes.